Hi guys, welcome back. We shall now be talking about renal tubular acidosis, which is of three varieties, 1, 2 and 4. Out of the three varieties, it is RTA4 that is most common clinically and is mainly associated with diabetic nephropathy. But currently we'll go in a serial order and first talk about manifestations that would be seen with RTA type 1, which is called as the distal variety of RTA, and it is the distal converter tubule that is involved in this case. From physiology, you are aware of these cells which are called as alpha intercalated cells as well as beta intercalated cells. Well, what do these alpha and beta cells do? The alpha cells are responsible for hydrogen excretion from the body, and the beta cells are responsible for bicarbonate excretion from the body. You can see why we study that the distal tubule plays an important role in maintenance of the pH, or plays an important role in maintenance of acid-base balance in the body. What happens in patients of RTA1, and I'll just put a line over this to say that alpha intercalated cells are not functioning. Why that is so, we will discuss. But at the moment, you have to understand that the main fundamental problem that occurs in RTA1 is that the alpha intercalated cells are not going to work. So there is going to be impaired hydrogen excretion from the body. In the MCQ, either he can write the word impaired hydrogen excretion or he can write the word inability to acidify the urine. Both mean the same. No, if you can't excrete hydrogen, you can't acidify the urine of the patient, and therefore metabolic acidosis will start occurring in the patient. The second manifestation that occurs in these patients is impaired ammonium chloride excretion. Now, why that is so? Well, the explanation for that is that the basic function of human kidney is to maintain electroneutrality. So if positive charges will not be lost, the negative will also be not lost, so that they will balance each other. I repeat once again, the positive charges are not getting lost, so the negative will also not get lost, so that positive and negative, they keep on maintaining a normal neutral charge. So in these patients, you get two things together, impaired hydrogen excretion, impaired chloride excretion in the patient. The third manifestation that occurs will decide the prognosis of this patient also, because one of the important functions of DCT is against salt being absorbed by the sodium hydrogen antiporters. So since salt is not absorbed in this condition, where the distal tubule, salt wasting will ensue. This in turn will now be triggering increased production of aldosterone. Aldosterone regulates sodium and water balance in the body. If you lose too much of salt from the body due to defect of the kidney tubules, then the values of aldosterone will be increased, and let us see what aldosterone does. The basic function of aldosterone is gain of salt and water. So it is trying its best to neutralize and get the salt back in the body. In that effort, it is also causing a loss in the urine of potassium and hydrogen. You know the normal action of aldosterone, gain of salt and water, loss of potassium and hydrogen. In this patient, I'm saying there is an exaggerated loss of potassium and hydrogen in the urine of the patient, and therefore hypokalemia component of renal tubular acidosis type 1 is explained by the salt wasting component. For the fifth manifestation, I'll put it like this, because this person is having metabolic acidosis, then this acidosis will impair tubular absorption of calcium. In the kidney tubules, we have these calcium sensitive receptors which help in gain of calcium. Acidosis environment in the cells impairs tubular reabsorption of calcium. The bad news is that this person will be having hypercalciuria. More calcium in the urine is again bad news, because it will chelate with phosphate, causing kidney stones in the patient. So nephrocalcinosis is a feature of renal tubular acidosis. Why? Because the calcium is not getting absorbed properly due to the acidic environment which has been created in renal tubular acidosis type 1. Therefore, the question then arises, after all, why is all this happening? One of the important causes for this could be multiple myeloma. The Bence-Jones proteins could be causing damage to the distal converted tubule. Then could be connective tissue disorder by the name of scleroderma. That is where you do that antibody test, anti-topoisomerase antibody. So the fibrosis is occurring in the distal converted tubule of the patient, and amphotericin B is also incriminated, the toxicity with it, with development of RTA1 in a patient. So apart from the three causes, one of the highlights of RTA1 which is to be remembered is kidney stones in a person. This condition will be having a development of metabolic acidosis, and he might write metabolic acidosis as either the word impaired hydrogen excretion, or he might just use the word inability to acidify the urine. Now let us compare the manifestations of RTA1 with that of RTA2. We shall now study regarding renal tubular acidosis type 2, which is characterized by damage to the proximal tubule. One of the primary functions of the proximal convoluted tubule is reabsorption of bicarbonate. So in these patients, you are going to read regarding bicarbonuria, and therefore the serum bicarbonate of the patient will be reduced. The proximal tubule is also responsible for absorption of salt. It is responsible for absorption of water. So most of the time, this condition is coexistent with Fanconi syndrome. What I mean by Fanconi syndrome is that the proximal tubule is malfunctioning because this part of the kidney plays a very important role in reabsorption of important, I would say, electrolytes as well as water. If you read a question that begins by saying that the person is having manifestations like phosphaturia or amino aciduria, whenever the tubules are damaged, they will always be salt wasting. So one of the integral features of tubular damage to the kidney is salt wasting. Along with that, water will not be absorbed, so polyuria. So all these manifestations, and then glucose will not be absorbed because glucose and salt, they go together here. So he will also use the word glucosuria. Whenever all these terms are written together, your thought process should be that it is damage to the proximal convoluted tubule, and this word you are not going to read anywhere else in your medical literature, that is bicarbonuria. This will explain the metabolic alkalosis in this patient. If you check out the serum bicarbonate of the patient, it will usually be between 15 to 18 millicoulomb. Normal bicarbonate in our blood is 22 to 26 millicoulomb, and here you can take an average of 24. In this patient, it would be values between maybe 15 to 18 millicoulomb only. Therefore, let us now see what will you do to neutralize the metabolic acidosis of this condition. I will be starting my patient on thiazides. Now see what they will cause. Thiazides will contribute to volume contraction because they will lose water from the body. Already is losing water from the body. Remember, I am causing more water loss from the body. This volume contraction will cause a decrease in GFR. It will activate the RAS system. It will upgrade the aldosterone. And now see what aldosterone does. The aldosterone that I have deliberately tried to increase in this patient will try to get back more of salt and water. So one, I'm trying to get back salt and water back into the system. Second, the hyperaldosteronism in this case will cause urinary loss of potassium and hydrogen. So you can see that because there is a urinary loss of hydrogen, mark my words, the urinary loss of hydrogen, it is going to contribute to metabolic alkalosis. Even if you don't want to get into this explanation, I can say like this, that from pharmacology, you are aware that one of the side effects of thiazides is metabolic alkalosis. My patient was having metabolic acidosis. I'm causing metabolic alkalosis in him. That means I'm trying to balance out the metabolic acidosis component. I repeat this description again. Thiazides contribute to volume contraction, cause a higher renin state. The more aldosterone causes urinary loss of hydrogen. You can see here hydrogen is kicked out. So there is urinary loss of hydrogen will cause alkalosis. Hydrogen is kicked out, alkalosis, and alkalosis will neutralize the metabolic acidosis component of the patient. So I'm trying to counterbalance the two. Apart from this, for management of this condition, I shall also be using the supplements that is in the form of soda bicarbonate, which can be given orally to this patient. And if required, if the pH is too low, we can give it intravenous replacement also. Why do you have renal tubular acidosis type 2? Then one of the causes is common between RTA1 and RTA2, that is multiple myeloma. Then another cause to be remembered is Wilson disease, where the copper which is present in the tubules is in excess, because you see Wilson is a disease of copper toxicity. So in the blood it is elevated, so in the urine it will also be significantly elevated, and then expiry date tetracycline can contribute to similar kind of manifestations. So nephrotoxicity with drugs, Wilson disease, and multiple myeloma are causes for development of this. From this discussion, you can also remember the fact that soda bicarbonate that is had oral can also be used for management of renal tubular acidosis type 1. So soda bicarbonate oral replacement is universal in all the varieties of renal tubular acidosis. It is just the fact that in RTA2, I'm trying to play around with nature. He's having metabolic acidosis created in the disease. I said, okay, I will counterbalance it by causing metabolic alkalosis, which is a side effect of thiazides. It will not cure the disease. I'm not saying that this is drug of choice. It is just that we can reduce the disability of the patient, or we are trying to rather mitigate the effect of the disease in the patient. Let us now compare this with the most common variety of renal tubular acidosis that we see in clinical practice, that is renal tubular acidosis type 4. This is usually associated with diabetic nephropathy. That's one of the important points to be remembered. Diabetes mellitus or diabetic nephropathy is associated. Other causes are relatively less commonly asked, but still you should know it, like AIDS, HIV nephropathy, chronic tubular interstitial disorder, CTID, or hypertensive nephrosclerosis are some of the disorders responsible for renal tubular acidosis type 4. The problem in this patient is that aldosterone is not able to function. Either aldosterone is not there or is not able to function explains RTA4. So let's look at the function of aldosterone once again so that we can get a better insight into this topic. Salt and water comes in, potassium and hydrogen is excreted. The problem in this patient is, I'm just putting a crosshair to say that because there is a resistance to the effect of aldosterone, salt will not be absorbed. So that is a universal feature of any tubular damage, that salt wasting can occur, polyuria can occur in a patient. But over and above this, a very surprising thing will manifest in these patients, which would be a development of hyperkalemia. Hypokalemia is a feature of RTA1. Hypokalemia may be seen even with RTA2, but hyperkalemia is one of the main features that is seen with RTA4. Along with this, there will also be inability to excrete hydrogen. Therefore, there will be a metabolic acidosis explained in the patient. The main feature why RTA4 is asked is the hyperkalemia component. And because of association with diabetes mellitus, I can say the fact that in diabetic nephropathy, when you give ACE inhibitors to reduce the progression, one of the side effects of ACE inhibitors is hyperkalemia, and RTA4 also causes hyperkalemia. So if you're not observant, you continue giving ACE inhibitor to a chap with diabetic nephropathy, his potassium might keep on increasing, not because ACE inhibitors are causing that tremendous rise. They cause a limited rise. But RTA4 is a separate disease process in the same patient. It will spike the potassium and can stop the heart. So the importance for you as a doctor is to keep a watch on the potassium, and if required, give agents that cause loss of potassium from the body, like sodium polystyrene sulfonate or patiromer can be used in these patients to neutralize the impact of potassium in the body of these patients. The main reason why this disease occurs is either due to aldosterone deficiency or is due to aldosterone resistance. The receptor epithelial sodium channel is not responding to aldosterone because of the damage which has been induced in this area. So, well, what will you do for this particular case for management purposes? Fludrocortisone, in case it is aldosterone deficiency, will help in improvement of the patient because I said hormonal deficiency. Dietary potassium restriction in these patients, so diet like banana or coconut juice etc. not recommended because they're rich in potassium for these patients. I will also give furosemide to these patients, though there's a disadvantage of this. There's already loss of water from the body, but I can use furosemide for shorter duration to stabilize the potassium values in the patient. And because there is a metabolic acidosis component present in the patient, so soda bicarbonate supplementation is uniform for management of all the varieties of renal tubular acidosis. So let us quickly compare the three varieties of renal tubular acidosis that we have studied today, that is RTA1, 2 and 4. For RTA1, the main problem is with respect to the alpha intercalated cells, due to which there will be a defective hydrogen excretion from the body. This hydrogen excretion, which is defective, in turn will affect calcium reabsorption due to the malfunction of the Cas or the calcium sensitive receptors. So the highlight of RTA1 which is asked in questions is nephrocalcinosis. The potassium values in these patients are lesser, that is secondary to the hyperaldosteronism component that would come up. In RTA2, it is damage to the proximal converter tubule. The highlight of the disease will be this word bicarbotonuria, or he might specifically mention the serum bicarbonate values of the patient. Normally it's 22 to 26, here it would be like 15, 18, whatever, it would be lesser than 22. A hint in the question, if you're not able to pick up by the bicarbonate values, will be amino aciduria, glucosuria written in a question, because these are not written routinely. They signify that there is a Fanconi syndrome component which is coexisting in this patient. When it comes to renal tubular acidosis type 4, then the reason for this is either a deficiency of aldosterone or it is a problem with respect to the receptor for aldosterone. The resistance is very much there, and this resistance to aldosterone is due to either diabetic nephropathy or due to HIV nephropathy, or it could be chronic tubular interstitial disorders. One of the highlights of this disease is hyperkalemia. Potassium values are always low in RTA1. They may be low. The word is may be low in RTA2, but they will always be elevated in RTA4 due to aldosterone resistance in the patient. There will be metabolic acidosis, which can be written in the MCQ as inability to acidify the urine. These are the comparisons that I want you to remember for this topic of renal tubular acidosis. Now, another important point for this topic. All of these varieties of renal tubular acidosis will always be having a normal anion gap metabolic acidosis. The reason for that is that anion gap is a difference of positive charges and negative charges in the body, and in all these diseases, positive and negative charges are equally lost. Therefore, there will always be normal anion gap metabolic acidosis. High anion gap metabolic acidosis can be seen like in diabetic ketoacidosis. The mnemonic for high anion gap metabolic acidosis I'll just mention before you. But these are the causes of and MCQ wise important causes of normal anion gap metabolic acidosis. How to remember high anion gap? The short form is HAGMA, high anion gap metabolic acidosis. The causes can be remembered by mnemonic, which is by the name of CULT, KULT, where K would stand for ketoacidosis, which could be diabetic ketoacidosis, starvation, or alcoholic ketoacidosis. U would stand for uremia. This could be due to acute kidney injury, chronic kidney injury. Lactic acidosis due to drugs, lactic acidosis due to shock, carbon monoxide poisoning. And T would be toxins like methyl alcohol poisoning or ethylene glycol poisoning in a patient. So most of the time the question that will come will be an all except question, like 3 choices will be from high anion gap metabolic acidosis and 1 choice will be of renal tubular acidosis, any varieties. That would be the question saying all are causes of HAGMA except, and the answer would be given as renal tubular acidosis that I explained. What you will notice nowadays is that instead of asking about the anion gap in the blood, he's also started asking about urinary anion gap for the patient. So at the moment, I would like you to remember this statement of mine that urinary anion gap is positive in renal tubular acidosis. I can go into the mathematics of that also, but instead of going into mathematics, we need to focus on the core issues that you need to answer. So remember my words, in the blood, the anion gap is normal, but in the urine, the anion gap is usually on the positive side in these patients. Urinary anion gap formula is different from that of the blood. It is sodium plus potassium in the urine. Mark my words there, we're talking about urine, right? It is sodium plus potassium, and from that we will subtract the chloride in the urine of the patient. So in these patients, most of the time, the urinary chloride is lesser because the positive charges are accumulating. The urinary chloride is lesser in all of these causes, and because urinary chloride is lesser, if you have paid attention, in the starting I was saying that if hydrogen will not be excreted, even chloride will not be excreted. So in all of these patients, chloride is not excreted from the body. So if chloride is not excreted in the urine, it will be lesser. And if just look at this formula, if chloride in the urine is lesser, then the mathematical value of urinary anion gap will increase. So let's just put one more slide here to remember aspects related to RTA, renal tubular acidosis. The highlights of this condition are it will cause a normal anion gap metabolic acidosis, NAGMA. HAGMA was CULT and NAGMA is renal tubular acidosis. For RTA1, you need to remember aspect of kidney stones association. For RTA2, you need to remember bicarbonuria or serum bicarbonate values which are given to be low. RTA4, you need to remember the hyperkalemia component which is associated with these patients thanks to the aldosterone resistance that develops in the patient. UAG means urinary anion gap in these patients is positive. So blood anion gap is normal and urinary anion gap is positive in the patient. That's all mathematical, no? So you just need to get a hang of these terminologies that I mentioned here. In all of these patients, for management support, soda bicarbonate will be given. We obviously need to give supplements, like if potassium is less, potassium supplements can be given. But soda bicarbonate oral supplementation would be used in all varieties of renal tubular acidosis in a patient. Then we also use therapeutic examples, like I said, that in RTA2 we might use thiazides in the patient, or in RTA4 we might give fludrocortisone for the patient. Fludrocortisone is used in RTF4. Why? Because it could be due to aldosterone deficiency. And furosemide is used in RTF4, whereas thiazide was explained for RTA2. So do remember these minor aspects that I mentioned here. And if you can just practice these details that I have mentioned for renal tubular acidosis, you will be in a better position to handle questions related to the kidney. Because if whenever they will ask you kidney, you see nephrotic, you know from pathology, no big deal. When it comes to the internal medicine component, it is mainly this detail that is worth remembering here. So I would rate renal tubular acidosis as a topic from the kidney perspective. I mean, if you know RTA, then you definitely know the kidney topic from the medicine perspective. That is my take on this, because otherwise polycystic kidney and nephritic, you've been studying that from third year, and you are able to solve questions on those topics even without, even if you don't go through the medicine questions. I would put it very frankly here. But then aspects like electrolyte imbalances, aspects like I have talked about Liddle syndrome, or I have talked about Gitelman syndrome, Gordon syndrome. Those are the aspects, which basically define kidney from the medicine perspective. So do try to pay attention to these atypical aspects, which will increase your scoring power. Thank you so much for listening.